Okay, good afternoon and hello, everyone. I'm delighted to have you join our next series in the Wellness, Resilience, and Survivorship seminar series. I'm really delighted to have what I view as really an all-star panel. As you're all aware, we've entitled this seminar series as Cancer and Cupid, the Sexual Side Effects of Treatments. I think we know, and I think this panel will agree that issues related to sexuality and intimacy and body image changes are incredibly common for somebody that goes through cancer treatment and its aftermath. And I put the blame and burden on us. I think probably as a system, we don't do enough and we don't pay enough attention to a really important topic. And we're really delighted to have our panel to kind of dive into this issue in some level of granularity. So before we start, I just want to take a moment and again introduce everyone who's really volunteered their time, and I'm really grateful for everyone's joining. I'd like to first introduce our guest, Dr. Stephanie Buehler. Dr. Buehler is a licensed psychologist and certified sex therapist and supervisor. She is the director of the Buehler Institute and creator of LearnSexTherapy.com, which provides continuing education in sex and relationship therapy for psychotherapists and wellness providers. Dr. Buehler specializes in sexuality and chronic illness and cancer in particular, and sexual pain disorders and sexuality and mental health. She's worked in several medical settings, including an integrated wellness center, Rady's Children's Hospital, and as a sex therapist at a major regional hospital. Currently, her clinical work focuses on training others and being involved in education and teaching providers to learn techniques for practicing sex therapy and sexuality counseling. And we'll mention this again at the end, but she's the author of several books, and we hope we can make this available to you, at least as a resource, including a best-selling book, What Every Mental Health Professional Needs to Know About Sex. And Dr. Buehler has spoken to professional audiences all over the United States and around the globe, and is frequently quoted in the media. Thank you so much for joining and welcome. In no particular order, I next like to introduce Dr. B.J. Reimel. She is an associate professor in the Department of OBGYN here at Cedars Sinai. She came to Cedars Sinai in 2011 to work on gynecologic oncology clinical trials, and her research interests focus on barriers to clinical enrollment and the use of digital processes to improve access and comprehension of clinical trials. She is the vice chair of the Protocol Review and Monitoring Committee at Cedars Sinai Cancer and the associate director of gynecologic oncology clinical trials. Dr. Reimel plays a significant role in our educational process. She's had a significant impact on the training of future physicians, and she serves as the site director for fourth-year medical student rotations in the Department of OBGYN. And I know personally she's quite busy and been a great resource for many of our patients who are experiencing side effects related to sexuality and survivorship. So thank you for joining. Next, I'd like to introduce J.K. Vandergog. He is the manager for Cedars Sinai Cancer Clinical Social Work and Population Health. He has been in practice for nearly 25 years, although I think he joined us about 2 or 3 years ago, and has worked with many people who have chronic conditions that affect gender identity, expression, sexual identity, and sexual health. I think he often shares, you might remember from a previous seminar, he is also a former opera singer, and if I may put a plug for him, he'll be speaking tomorrow at the Cancer Support Community about the role of music in healing. So please check that out as well. Last, but certainly not least, I'd like to introduce Dr. Ariel Mouradzadeh. He went to UCLA School of Medicine and went on to do his general surgery internship and urology residency here at Cedars Sinai. He left briefly to complete a men's health and male infertility and microsurgery fellowship at UCLA before coming back to us at Cedars. And his clinical interests include pre and post prostate cancer sexual health, testosterone management, erectile dysfunction, male fertility preservation, as well as all aspects of male subfertility and infertility. When he's not busy practicing urology, he enjoys running, swimming, yoga, and I didn't know this, running a finance podcast. Are you running one, or you listen to one? I missed that.
Oh, I listen to one.
You listen
while
to
I'm
one.
running usually, but yeah, I do just listen.
Combine it together. Again, I want to mention to our audience, everyone's volunteering their time to be here with us, to be here with you. Before we start, I want to remind everyone that intentionally for this particular seminar series, you don't have cameras and mics. So we want to encourage you to feel free to ask questions in the chat box. I'll serve as moderator and let our experts manage as best as we can. And we'll probably have about 40 to 50 minutes together to go through some topics. So I'm going to just start with a general comment and ask our panel to chime in. One of the reasons, again, I'm really delighted to have the breadth of your expertise is I think we can all agree that when we think about sexuality after a cancer diagnosis, in my mind, this really brings up what's known as the biopsychosocial model, and the idea that, right, there are biological factors, medical factors that contribute to these concerns. There are issues related to our mood and our psychological well-being, and of course, issues related to culture and how we're communicating with our partners and our relationships and whatnot. So really, it touches upon everything. And given that context, if I may, I'll just start with this general question. When should our patients be talking to their healthcare providers about this topic? Because I could tell you again, and I promise I'll be quiet in a second. From what I see, oftentimes, and again, I may have a biased view of the world, it's almost as if many of our patients with cancer are like in warrior mode during, the period of surgery or chemo and radiation. They're just focused on the task at hand. And then when it's all kind of done, then these issues and concerns just pop up and may not have been. And often we just don't spend enough time talking about these things during treatment. So when's the ideal time? When should our patients talk to their providers? Dr. Ryan, yeah, anyone.
I'm going to say, I think that is such a great question. I think you are so right. And the patient and their partner, if they have a partner, like I'm starting to call the partner the co-survivor, you have to get well. I mean, that's the most important thing. But I think as soon as the person starts to have more energy, I think either the co-survivor or the survivor will start to, one of them will start to think, how are we going to get back to normal? And for most people, if they've been sexually active up to that point, normal is going to include getting back to their sex life. I think as soon as you have that inkling, one of you or the other has that inkling, it's time to bring it up.
May I ask one of our physician colleagues, from your perspective, is there a more optimal time or suboptimal time where these things can be discussed?
I think that in gynecologic cancers, a lot of our surgeries require the removal of certain reproductive organs, specifically like the uterus, for example. And a lot of patients can and should feel free to ask about sexual function after the surgery. Like, what could their expectations be? What limitations might they have, at least initially? What could be the long-term limitations for certain surgeries? For some of our rarer cancers, some of their sensation may be decreased. And I think it's reasonable, important, and very helpful to tackle some of the what ifs before the surgery so that the patient doesn't have to experience that sense of what did I just agree to, finding that all out after the fact. I think that the important conversation for us to offer to our patients. And I know as a gynecologist, like I frequently have to say things like, this is going to get awkward for a minute, but let's just talk about what are your practices? What are the kinds of things that you do? And, what kinds of things are you worried about? Because I assume that nobody wants to actually just ask me. So I try to bring it up in our conversations.
Well, if I may follow up on that for just a moment before Dr. Muradzadeh chimes in, let's say our physician does not bring it up. Do you have a suggestion for anyone on some kind of language that they can use to ask some of these kind of important questions?
Go ahead, Dr. Muradzadeh.
Yeah, so I want to first start by saying thank you so much for having me be part of this panel of esteemed colleagues. I really love to meet with patients, even before they end up going through, prostate cancer surgery or radiation. I always do what's called pre-prostatectomy counseling with the patient to get them to, I have them come in with their partner as well. And we kind of sit down and have a discussion together about the challenges that we, three will be faced with moving forward. From a sexual health standpoint, I try and optimize them and have them do a series of exercises and different things that we talk about during the visit to give them the tools needed to optimize their success after surgery. Even in the most clean bilateral nerve sparing prostatectomy, there will be a period of nerve traction injury called neuropraxia where erections are just not going to be possible. And to be able to have this discussion with the patient and their partner so we can all come to a level of understanding that there will be a period of time where it's going to be very important to be super understanding and supportive till we all get through this kind of phase of neuropraxia and get on to the next steps where we can really kick it into high gear and start recovering sexual function. So I think the discussions would really benefit the patient to be had prior to surgery or even prior to radiation, where they can be armed with the tools necessary to kind of get through this big step that's laying ahead of them. So best things patients can do, just bring it up, say, hey, doc, I'm having this issue, or this is on my mind. I really need to talk to someone about it, and just bring it up. Very briefly, I had a patient today who saw me for elevated PSA. So not even down the pathway of prostate cancer diagnosis. I just casually asked him, I said, so tell me, what are your any difficulty getting an erection, difficulty keeping it? He said I was the first urologist, and he had seen another urologist before, and I'm not throwing anyone under the bus, but he said I was the first urologist in 10 years to ask him about his erections, because everyone else was just asking him about his PSAs and monitoring his prostate. So I think it's really important and an underutilized aspect of our job as providers to really delve into one's sexual health and really be there for our patients, especially in this time of need.
Yeah. And I want to open up the topic even larger, right? Because I do think these conversations are very helpful to have with the doctors. And I think there is the reality that energy impedes sometimes, and physical function will impede on sexual activity. But I think the whole concept of sexuality is really important. And, one way that I help people through dealing with not being able to have erections or other parts that are working is to recognize that they have other sexual parts in their bodies as well. And really, I think the larger conversation is, how do you step into what is your sexuality? What are other ways of expressing it? My view is that to get through cancer, you need all of you. And I think sexuality is a really important part of you. So I'm always big on figuring out where are the different places to have the various conversations around sexuality. And I really do agree that, when you're going through chemo or when you're having things altered on you, you don't feel sexy, right? So really being mindful of that and figuring out, how can I step into that, even though this is happening, right? Because like I said, I'm all about trying to embrace the whole person as they go through this.
So I have kind of a unique perspective. One that I like, it's unfortunate that I'm in this position, but fortunate that my husband is okay. He's in the room next to me. He was diagnosed with prostate cancer earlier this year, and he had a prostatectomy. And I will tell you that he felt awful, and for maybe 6 months, just draggy, bad, sad, miserable. He's only just starting to feel like himself. I can see, like, I'm going, oh, okay, there's his humor. There, he's kind of perky. He's interested in, he really got rather depressed. So I think if you are, even if you're armed with a lot of information, to realize that it's pretty normal to feel awful, and that both partners need to be patient. So it's been very interesting to be a sex therapist and be married to someone who, lost his sexual function. He's open about it. So he said, I can talk, I'm allowed to talk about it. And it's been really a journey for us as a couple. We've been together 40 years. So it's been quite an interesting journey, I will say.
I appreciate your openness and how playing that different role really is almost uncanny in a way. But I would like to go back to something that Dr. Muradzadah said, and I'd love to come back to some of the psychological pieces. You alluded to the exercises, and I may be biased as a rehab person, but when would be the appropriate timing for bringing in a physical therapist that specializes in some kind of pelvic floor rehab, either for men or for women?
So I hadn't found it to be all that helpful in the return of erectile function setting, but in terms of pelvic floor physical therapy for return of urinary continence after radical prostatectomy, that, I'm a huge proponent of pelvic PT for return of continence, but also for patients with pelvic floor dysfunction, just inability to get the urinary stream going from having, tonic or hypertonic pelvic floor. I find that PT is very helpful. Also for patients just generally who have constipation and they're very anxious people, I find that having, meeting with someone to relax those pelvic floor muscles really gives them a lot of benefit in that. But as far as from a sexual health standpoint, I don't necessarily use pelvic PT in that space.
We use a lot of pelvic floor PT in GYN, an enormous amount, especially after radiation therapy for different kinds of GYN cancers. And we use a lot of pelvic floor PT, even for patients that never had radiation, to help with some of the sort of post-treatment effects that can happen in the female pelvis. And that tends to be a really great space for patients to be able to interact with a provider who's, doing some manual manipulation and talking to them frequently about, sexual function that happens outside of the office, which I think gives patients some more freedom as well. So we use a lot of pelvic floor PT. And for us, the only limitations are recent pelvic surgery. So as long as the top of the vagina is healed, all things are go. So there's no restrictions for us on starting. It's just really when the patient's healed from surgery.
As we're discussing some of these topics, I'd like to, because I know there's some questions that are coming up in the chat, and for the benefit of the entire audience, because I don't think they can see what comes up, I'm going to read a couple of them and maybe we could share. I know, Dr. Muradzadah, you answered one of them, but just to open this up, one participant asked the following: is there some option for erectile dysfunction between pills and penile implant? Do you mind commenting further?
Yeah, not at all. So there really are a few rungs on the ladder in terms of treatment for erectile dysfunction or even erectile dysfunction following radical prostatectomy or radiation. There's pills, comes in a variety of different half-lives. There's Cialis, Viagra, Levitra, Stendra, which is the new one out into the market. The onset of Stendra is about 15 minutes, and peak efficacy is about 45 minutes. In terms of next steps, there's actually an intraurethral gel. It comes in a pre-filled syringe. The patient instills this gel into the urethra. There's no needle involved. It's kind of the consistency of hand sanitizer that can give you an erection. The next step is intracavernosal injections, where we teach the patient to actually give themselves an injection just into the side of the shaft with a small little diabetic needle that comes in the name of trimix, or there's bimix and quadmix, different substituents that are vasoactive agents to give you an erection. And then kind of the last rung on the ladder really is putting in a penile implant. And I do many penile implants. I did about 100 last year. There are multiple components. There's a reservoir that you implant in the abdomen and a pump that you put in the scrotum. And as you pump up the pump, it pulls fluid from the reservoir, and it inflates the cylinders that give you an erection, and the erection will last as long as you want it to for sexual satisfaction. And then when you're done, you push a deflate button, and it pulls the fluid from the cylinders back into the reservoir.
Thank you. And I'm just going to go through a couple more questions, and then we'll come back as a group. Another participant basically was alluding to the idea that she's been treated with multiple types of chemotherapy and surgery and radiation for ovarian cancer, and issues related to sexual health was not brought up, and raising the possibility that there might have been some challenges if the physician was of an opposite sex as the patient. And I guess that brings up an important question in terms of, are there biases or issues related to discomfort on our part as physicians if we're of the opposite sex? Should we be encouraging our patients to meet with a different provider?
Wow, that's a great question. I don't know if there are many people on the treatment team that may be able to answer some questions or that may be able to guide that person to somebody else. Obviously, the relationship someone has with their oncologist can get pretty deep. And so I wouldn't necessarily say you got to see somebody else. But there, at least in GYN oncology, there's always a nurse in the room. It's, in my case, it's the same nurse for the last 10 years, God bless her. And she often will stick around after the visit's over and just double check and make sure everything's okay. And did you have any last minute questions or anything you don't want to tell her, but you'll tell me? And we kind of have a thing going where that can help a lot. So I would say you can always reach out to your nurse. You can reach out to the infusion nurses that know all of the supportive providers. So there's always supportive care folks to talk to, and people in JK's group as well, which I feel like, we frequently will bounce situations or patients back and forth to provide the very best fit, the place where it feels right to talk about those things. But the door is also always open within each individual unit. Like, we're all happy to see each other's patients, especially if something just feels like it would be easier said to somebody else.
Great, thank you. I'll come back to some of the questions in the chat in a moment, and again, please feel free to jot that down. Dr. Beard, I'd like to follow up on some of your expertise. Let's say we have NJK as well, and anyone else. Let's say there's a patient who has had the medical aspects managed as well as possible. So they've optimized their medication regimen, their rehab regimen, but there are still barriers to their sexual health, and this individual is then seeking some kind of psychological therapy. Can you describe what this process might look like? I mean, I could imagine many of our patients, when you tell them, you should see a psychologist who specializes in sexual health, they may not know what that experience may be like, how many sessions are usually offered, et cetera. Any wisdom you can share?
Yes, also a very good question. So sex therapy is just a form of psychotherapy. If you've seen, most people have seen, even if you haven't been to a psychotherapist, you've seen it on TV where the therapist is sitting in one chair and the client is sitting in the other chair, and there's just a conversation. These days, it's mostly a conversation, a dialogue that happens. But in sex therapy, it's focused on sex. there's no disrobing, no undressing. There's nobody's going to be with a stopwatch and a clipboard trying to figure out how you have sex or if you're having sex the right way. And with cancer survivors, it's really about understanding how your particular treatment has affected you, what body parts have been affected, how your hormones have been affected, what your energy level is, what your sex life was like before. Some people have problems because they had problems before and now they're just kind of exacerbated. Other people just have a hard time getting on track. I'm kind of looking at the chat and seeing comments about libido, and that's kind of that can be very psychological as well as physical. So, they need some support and some information, and maybe a place to talk with their partner about things that are difficult to talk about just sitting at home. That's what sex therapy is about.
Thank you so much. I'm going to go back to, JK, any comments before I go back to the chat?
No, I mean, I agree. It's a conversation, right? And it's really figuring out identifying where you're struggling, but also really figuring out what different ways are to approach it, right? I mean, I think cancer often challenges us to rethink how we do things and how we've lived things and what is meaningful for us and what's not meaningful. So for me, it's always a very large picture, right? And there's different ways to enter into sexuality and sex and what may work for you in the future and what may not. I think there's lots of revelations along the way that are possible. So being open to that, and but the first step really is recognizing that in this culture it's hard to talk about sex, let alone dealing with cancer in this culture, and then on top of it, then trying to approach a stranger to talk about sex. It's a very vulnerable process, especially when the cancer affects your sexual organs. You're constantly being exposed, and it's hard. And to keep the energy going to have these conversations and embrace these conversations, it's a hard steps. I know that from my team and the people that you see in front of us, we're very willing and able and wanting to help you, but crossing that first step is really, really hard. And we want to honor that.
Thank you very much. I'm going to go back to the chat, and this came up, I think, among a few individuals where they were basically writing about the idea that presumably related to their treatment. One person wrote about a hysterectomy, that they lost their sense of libido. And of course, by that, we mean just the lack of interest in sexuality. How do you manage the loss or the decrease in desire? Knowing it's a complicated issue, and I don't think but how do we approach that topic when just the interest is not there like it used to be?
I think that's really hard because the chat also mentions a lot of other things that go along with normal libido, like lubrication, not having pain during intercourse, or things that take libido away. So you might have been interested, but now there's pain, so it's over. Those kinds of things all have sort of different aspects. When another person mentioned the inability to climax, despite being told, of course you can, which is not helpful. Like every person's response to medication is going to be highly variable. And estrogen and all the other magic things that ovaries do, when it's gone, like sometimes seems to have rather sort of mysterious things that happen to people that aren't well described, and we don't always have a great solution for. But the loss of libido is so multifactorial, and it's such a vulnerable place to be, right? Because the person is saying, I'm not only not interested, but then maybe I was, and then this thing happened, and now I'm feeling stressed about it, and now I don't want to ever think about this again, or my partner and I got into an argument, and now I feel sad about that argument, and I'm worried about my caregiver is going to keep taking care of me. So it becomes a big thing, and I think it requires all of us, right? All the physician folks and the social work folks and the psychology folks, all to be on the same page about this, which is that these are problems that require help and that we have help to give. And so to just echo what JK said, like this is a really great place for patients to just even the tiniest little step towards us, we have a lot more resources, I think, than people are aware of.
Right. I think a lot of the times, and I've personally heard this, and I'm sure you have as well, is one of the challenges is just making the resources and services just visible, just and just people saying that I had no idea you had this person or this other program that might help. And again, that's one of the reasons we're trying to do programs such as this one, is just to kind of raise some awareness.
I'd like to say something about drive, libido. I think, if you had the experience of having like spontaneous desire, like it could be just that you look at your partner, you've had a great time and you're feeling desire. A lot of times that's what goes away, right? That feeling of spontaneous desire. I think if you can think in terms of responsive desire, what can your partner do to help you respond to their initiation? It kind of puts the onus on the partner, but it can be helpful. I remember I had a client who had, she'd had double mastectomy, and what she realized is that she needed her partner to just give her like a long back rub before, so that she could relax and just get in a different mindset. And then she was fine. She could participate and enjoy herself. That took, took a number of sessions for her to kind of identify what that is. But maybe if you could sit and think, what do I want now that my body has changed? What might get me in the mood, instead of waiting for the mood to hit you? So I'm just giving that as it might not be pertinent to everybody who's making comments, and I know that. I know somebody might be saying, well, that's not me. That, but for those that it does fit or that it resonates with, you can think about that. Like, what would work for me now? How has my body changed? What would feel good? What could we do that might be fun, or we could explore, we could experiment?
Yeah, to add to that, right? I mean, I've certainly sat with a lot of people who had limited sexual practices before these experiences, and now had to really become curious and explore lots of different options that may ultimately result in a much larger repertoire of options than they had before any of this started. So there is some good news possible in it, even for the people where the actual organs may or not function the way you want to, or the pain is always present, right? That doesn't mean your sex life is over. It may mean that part is not working right now. But like Dr. Reimel said, I think the challenge is navigating, acknowledging that it's not working right now, but not building up that pressure and anxiety around it, which then actually makes it more difficult to get going, right? And that's a real paradoxical situation to be in, but usually exploring it through the other ways kind of relaxes you into it. And so I love that example that you just gave there about how to relax, right? Because there's so many different aspects. It's the physical, it's the mental, it's the emotional, it's the hormonal, like people are addressing. There's so many different things we try to get to line up, right? And just figuring out where that entrance is I think, really helpful.
And another thing also with my prostate cancer survivor patients, talking to them and letting them know, look, even in the post-operative period, while we're dealing with the neuropraxia from the nerve injuries, you don't need an erection to achieve an orgasm. An orgasm in a male can be achieved without an erection. So there are other ways to participate in intimacy with a partner without needing to have penetrative intercourse. So, talking to patients and explaining these things to them and just making them feel the sense of empowerment that, I'm doing something towards returning to some sense of normalcy. Also, I can't emphasize enough the importance of having the discussion with the patient's partner as well, having them come to the visit. So, we're giving everyone in the room all the information and all the tools, because in order for a male to achieve an erection, it's really, for lack of a better term, it's a performance. And in order to get ready for this performance, you need to have optimal relaxation, because stress and norepinephrine or adrenaline in lay terms, will counteract the effect of achieving an erection, because an erection is a relaxation phenomena such that the nerves that send the signal to the penis release chemicals like nitric oxide that cause the vessels in the penis to dilate. If you have stress on board, the norepinephrine will counteract the ability to achieve an erection. So, relaxation is key, and having a very understanding partner will definitely help with that.
That's a great point, and it gets me, if I could ask a follow-up question on what you just said, Dr. Muradzadeh. I mean, it's been at least my experience, and maybe you're aware of some research in this arena, that people that have participated, for example, in some kind of structured exercise program, whether it's ours or something else in the community, one of the things I've heard is sometimes, and I think, again, there are many reasons for this, as they get more fit and are exercising more regularly, that their libido and some of their concerns related to sexuality have actually improved. And I was never sure if that was related to maybe improved body self-image and body image, or if there was something physiologic that may be at play. I'm not sure if you're aware of any research or insight on. I know there's been some studies looking at that, but I think they were inconclusive.
So, I think it's actually both. So I'm a huge proponent of 3 simple things, and I tell all my patients: eat, move, sleep. Eat a balanced diet. I really recommend a Mediterranean diet, just because you get good protein, good fats, omega-3, omega-6. The move aspect, 30 minutes of vigorous exercise, at least 5 days a week. I tell them, you want to exercise vigorously to the point where you can't easily complete a sentence. And then sleep is a real key component to the eat, move, sleep. 7 hours of sleep. I tell the patients all the time, turn off the blue light setting on your phone, because that'll suppress melatonin release. Try not to look at a TV or a tablet or your phone about an hour and a half before bed. In terms of your question, Dr. Asher, about does exercise kind of re-trigger or re-stimulate the libido? I think it does. The endorphin release from exercise, the general sense of feeling well, and the body undergoes changes when you exercise, and that kind of plays into even subconsciously in one's psyche about feeling good about oneself and feeling quote unquote attractive to your partner. And I think all those come into play. I deal mainly with men's sexual health, but I think, both for men and women, that definitely could play a factor.
Great. Thank you. Before the session, I had communicated with Dr. Reimel, and I just wanted to go through some of the questions that's come up for many of her presentations, because I think they're important. One of them was, can I safely have sex with my partner during chemotherapy? Can you?
Usually, yes. So there's a lot of fear about, especially if patients have had certain chemotherapies or have had recent radiation, that their partner may be affected by the excretion of chemotherapy through sweat or through other kinds of things. And in general, for women, your partner should be fairly safe. There's no reason to not engage if that's something that you feel that you want to do.
Thank you. Maybe there's a few other questions in the chat that I'd like to address. Another participant asked about how useful pelvic floor physical therapy can be for pain during intercourse for a breast cancer survivor that has maybe some challenges due to aromatase inhibitors, so lack of estrogen. And the second part of that question was how accessible physical therapy is, and whether it's covered by insurance, and if there's anything else that might be helpful.
Sure. So for the general record, the aromatase inhibitors and anti-estrogen therapies, one of the most commonly cited side effects was what in medical terms is dyspareunia, which is a completely heteronormative term about sex. But what they really, I think, tried to say is people have pain in their genital areas when they are on this medicine, which we think is due partly to vaginal dryness, which means that the lubrication that normally coats the vagina and vulva is absent, thus making things dry or itchy or even just painful. The second part of that question is about pelvic floor physical therapy. So a combination of lubricants, because we can't always give patients back estrogen, right? We've tried to take it away for cancer purposes. We can't give it back, but we can give lubrication to the area. We can also give, my brain just like totally fried. So we have lubrication out, and then we have moisturizers, right? So moisturizers are different than lubricants. Lubricants are for sex, whatever that looks like. Moisturizers are for daily use and can actually help build the skin back up, make the lining of the vagina a little thicker, make the vulva a little less sensitive, and are used for daily use. So if you imagine you had a rash or dry skin, you would put a moisturizer on it. There are special vaginal moisturizers specific for the vagina and vulva that are better used when people are having that kind of pain. And that preparation for sexual encounters can really help people feel better and have less pain. Pelvic floor therapy is great for pain that is the result of muscular, mostly spasms or muscular discomfort. Sometimes pain with penetration can be particularly solved or helped with pelvic floor physical therapy, which is the manipulation and teaching patients how to use and not use certain muscle groups in the pelvic floor. And it's very accessible. We have them obviously here at Cedars, but there are multiple pelvic floor physical therapists throughout LA County. Physical therapy is covered by most insurers for a certain number of visits per year. And so you can look at your insurance and figure out how many visits you have. And it's per diagnosis. So don't worry if you had shoulder PT and you need pelvic floor PT, you can still get pelvic floor PT. And you just have to ask for it. And your provider puts a diagnosis in and they see and treat. It's pretty simple. And I think that's all the things I had to say.
Great. I'm going to go to another question in the chat, and I really appreciate the questions that are coming in. Somebody else asked about physical changes that might result from radiation to non-reproductive areas and the effects of chemotherapy on, again, sexual health.
I can jump in.
Please.
So my experience is that when folks get radiation to other control areas like brain, head and neck, stuff like that, there are actually some sexual repercussions to that, especially when people have issues with sort of like memory and libido after whole brain radiation or other, even SBRT, which is that focused radiation that's often used for brain cancers or isolated metastases in the head. People can still have those kinds of issues. And again, it's going to take a multidisciplinary approach. There's going to have to be your physician and possibly your psychologist and your social worker and all these people to try and help figure out exactly what the fix is going to be. And there may be some trial and error, but we do see that. Another issue that's come up in my practice is that I treat a lot of folks who are sex and gender minority patients, and their mouths are really important to how they have sexual intimacy. And so if they have a very dry mouth as a result of their chemotherapy treatment, or especially radiation to the head and neck, we find that it's difficult to get excited about doing some of their normal practices, and then kind of got to think out of the box, like JK mentioned, coming up with a larger repertoire of options.
And I would just like to add very briefly that I think it's very important for your physicians to review your medication lists. And I know it's a cycle in the sense that sometimes because of mood changes, which can contribute to sexual health changes, your physician may opt to start an antidepressant, for example. And we know, for example, some antidepressants can actually contribute to some of the changes in either libido or ability to orgasm also. So it's worth taking a close look to see if there's any room for optimization in what medications you may be on. I'm going to go to another question. What are contraindications for using Reverie? Anybody feel capable in answering that question, or also known as hyaluronic acid?
I don't know about that.
Okay, so thank you.
I don't know about that either.
Sorry.
Okay, sorry. We'll try to take that one later. What is the name of the moisturizer for daily use that Dr. Reimel referred to? Is it available over the counter?
Yes. So all the vaginal moisturizers are available without prescription. There used to be a company that came out of the UK called Yes Vaginal Lubricant. They went under during COVID, but they were my favorite. My second favorite is Replens, which is also the easiest one to get, and CVS and Walgreens all carry it. But you're basically looking for something that is a vaginal moisturizer, not a lubricant, and that has it'll say pH on it. And you want to look at the pH and make sure that the pH says less than 7, because the vagina is an acidic environment and we don't want to put other things that are not acidic in there. So that's really important. And then if you're having problems with it, bring it in, let us see it, let us help you. We can always try something new.
I want to think back, thank you, Dr. Reinbold, something that Dr. Moradzadeh alluded to in nutrition. And I'm sorry, but I couldn't help but think about that Seinfeld episode. And I forgot what it was. Was it mangoes that one of the characters was eating and that markedly changed their libido? And I think it's a question that many of our patients will ask. Is there any truth? Is there any scientific credibility that certain foods might, dark chocolate, like I get that question, or whatever, might improve libido or sexual health? Does anybody have any insights? And somebody said Kramer and George. Okay, mangoes. It was mangoes. That's what I thought. Is there any credibility to mangoes?
I don't know the mango story for men's health standpoint, but I know things like, nuts, avocados, pomegranates, dates, things that, and this is a lot of it's anecdotal. You'll see some men's health blogs post about this, but, things that I think have, omega-3, omega-6 fatty acids, I think could potentially play a role in boosting libido. I also have heard red meat, although I don't eat red meat, and I think red meat's probably not great for other, risk factors and, animal cruelty and all that other stuff. But, I think red meat also, there's some studies out there that show that it can boost libido.
There's more of a placebo effect.
I was just going to ask you, from a psychology perspective, in all your years of practice, have you found any credibility to any of these? Two people in the chat actually, like simultaneously wrote about oysters, and
I think that, yeah, I think these foods kind of they look like certain body parts, and so it's a very kind of almost superstitious way of thinking. And yes, there might be some vitamins or minerals that might help, but for the most part, I think people who say that they get a boost, it's psychological. So lucky them.
Thanks very much. Another participant asked about the new erectile dysfunction pill. And any comments? And I'm going to direct this to Dr. Moradzadeh.
I was typing the answer to him, so I don't know if it's showing up on the chat, but yeah, it's called Stendra. It has the shortest half-life of all the PDE5 inhibitors, so it's about 15-minute onset. The only problem with Stendra is that it's brand new, it's not off patent, so there's no generic variant of it, so it's going to be expensive, it's going to be pricey.
Thank you very much.
There is Stendra called Atlantic. No problem.
I want to be mindful for time, and because I see we just have a few minutes left. So feel free to bring in any final questions. Dr. Buehler, since you've been very prolific and published in this area, would you mind sharing? I think earlier you mentioned one of the more recent books you've written that might be applicable in this space. Maybe talk a little bit about your book, yes, and who it might be a good fit for.
Yeah. So, and I do want to mention a colleague of mine, and I will put that in the chat. It was Dr. Ann Katz, who has many books about sex and cancer, really most any kind of chronic illness. So that she would be a great resource, Dr. Ann Katz. And I did just update a book of mine called Enliven Your Sex Life. It's don't settle for boring sex. So, you've heard mentioned like try different kinds of sexual behaviors, expand your sexual repertoire. This book is for couples that are maybe a little embarrassed to talk about sex or shy in talking about it. It's really great basic information for people who maybe didn't get a great sex education, which is most of us.
Thank you. I realize there's a few questions we didn't get to earlier. One viewer asked, do our patients get referred to our social workers or did they get referred from the start? And I think it's important to at least describe our practice at Cedars. JK, obviously this is for you.
Yeah, I mean, I recommend that meet with a social worker and talk about your needs and your concerns. And if it's in the wheelhouse of the social worker, I think you most are very likely to work with them. But if it's decided that maybe somebody out in the community might be more useful to talk with, we will make those linkages happen. But it's there's not a formula or magic pill or steps that we take per case, each case, right? It's really case specific. We want to know what the situation is. And definitely my social workers are very comfortable talking about sexual health. They also have limits to what they know. And depending on who you meet with, right, they're going to tell you, you know what, I can go this far with you. And we recommend these as next steps. So I think it's a great starting place, and not just for sexual health, for any kind of things where you're trying to navigate psychosocially, right? Social work is a great starting place to figure out what are the next steps after that. And I also, I know we've talked, I don't know if we don't really have a lot of time, and this might be a really large topic, but I want to also acknowledge that there's probably single people in here. So the whole world of dating and sexuality is a huge topic, and that might be another seminar that we do all together. But I want to just acknowledge that that is real, and it's hard to go back to dating after cancer. And again, our team is fully trained to address those questions as well and really offer support with that. And I don't want people to feel shame or embarrassed that they had cancer and now they're no longer valid to go back in the dating world or anything like that, right? There's a lot of stigma associated, and I want to break through that and invite people to come and talk to us about it and get support in figuring out how to go back into the dating world. With or without cancer, I will also say dating is super hard these days. So I just want to honor that to begin with as well.
I think that would be a great topic. And by the way, I think Lisette sends out surveys on interest for future topics. So if any of these resonate with you, please let us know. Yeah, it's already getting some attention. So so somebody else wrote about lubrication oil base, and Dr. Reimel, do you mind commenting on that? And by the way, I'll add to that because, and I don't have a good answer. Many patients have come to me and just asking about coconut oil, and whether that's a good source. And I'm gonna throw one more question before I forget. So I'm gonna throw them all at you. There's a lot of controversy also out there about the Mona Lisa procedures. Oh. And I know I'm throwing a big topic in the last 2 minutes, but at least if we can touch upon it for a moment, I think that would be of value to our listeners.
Sure. So really fast, lubricants come in 3 flavors: water-based, oil-based, and silicone-based. They each have different benefits and drawbacks. The benefit to a water-based lubricant for somebody that is low estrogen is that the water-based lubricants tend to come in the exact right pH, and they'll stay that pH because water is their basic thing. They don't last very long though, and they can give out in the midst of what you're doing and be a complete wreck. If you didn't have any, like you're at the end of the bottle and there's no more left, and what do we do? And now so just have plenty. Silicone-based lubricants last a long time, but taste terrible. Enough said. Oil-based lubricants often don't taste that bad and can be natural. So everybody loves coconut oil. It's good for everything. If you're going to use coconut oil, please put a towel down or you will ruin your sheets. Put the coconut oil, if you're going to use it vaginally, is hard to get inside. It's messy. It'll get all over your hands. So you can put a small drop, like a little teeny drop, on a piece of wax paper and put it in your freezer for a few minutes. You can then peel that little drop off. It'll be solid for a few minutes, and you can slide that right into the vagina, provided that you don't have a coconut intolerance and your coconut oil is good and it's pure and it's all nice things. You can see how it goes. Put a towel down. It will not give up, which is great. So it's a pretty long lasting thing, but it can be kind of messy and sometimes just doesn't distribute super great. But you can just try a bunch of different things and see what you like. So those are the lubricants, sort of like my quick thing about it. The Mona Lisa laser, also known as fractionated CO2 laser, is a non-FDA approved device that uses tiny beams of CO2 laser light to make holes in the surface of the vagina in hundreds of rows. Okay. And so if you've ever had a lawn, we don't really have these in California, but when I lived in the Midwest, everyone understood this. So you've had a lawn that is thatched, right? So the grass is all grown too tight and you need to spring it up, or you've been to a golf course where they're doing this and they cut all these little cores out. That is what the CO2 laser is doing. It's cutting all these little cores out, and then the collagen will grow back in. Okay. So you make tiny micro injuries and the collagen will reform. For some patients, this has been wonderful. If they have vaginal stenosis or significant atrophy because of long-term loss of estrogen, this can really help some folks and they really like it. What we do not know about it, because it's not been studied, is whether or not it is safe to use after radiation. And we do not know if it is safe to use if you have an active HPV infection. But if none of those things are true, that might be a nice option. There's a phase 3 study that is supposed to result this year called the Velvet study, which is looking at comparing people who can take estrogen replacement versus people who got the fractionated CO2 laser alone. And when that data comes out, we'll have a lot more information about how to use it, who to recommend it for, and God willing, we'll have some insurance coverage. It's about $2,200 right now and not covered by insurance. And that is a shame.
Great, thank you. I realize we're at the end of the hour. I want to do two things. Number one, thank all of our participants for joining. And again, this is our attempt to try to stay connected to you during this, continuing pandemic. I hope we get to the point where we can do this in person, or at least some kind of hybrid module as things evolve. I want to again thank so much. Remember, everyone here is volunteering their time to be with you. So Dr. Muradzadeh, thank you. Dr. Reimel, Dr. Bueller, thank you. JK, I really appreciate your service and your efforts to bring, shed some light on an important topic that, as we heard from many of our comments, sometimes may not be adequately addressed. Please give us feedback on future topics and ideas that you'd like to see. Is there any kind of concluding comment or remark that anyone has in the last minute or two?
I have one. It's persevere. Don't give up. You can have a sex life. You just may need to experiment and try a few things.
I think that's probably the best way to end. And again, thank you all so much and hope to see you for the next seminar.
Thank you.
Thanks
Bye,
so much.
everybody.